Okay, good morning. We are going to continue with blood pressure, which is where we left off from or before break. So I've just got a little bit more to add about blood pressure. So continuing on with that, um, by way of review, we have blood pressure expressed as systolic blood pressure over diastolic. So systolic is going to be that top number, and diastolic is going to be the lower number. Systolic is representative of um, the peak in pressure during ventricular systole, which is what we see when we look at the pressure curve like this. Here's our systolic blood pressure. So it's going to be the high point because that's the most pressure that the heart generates during contraction. Diastolic pressure is going to be the low point. So that's what we're going to see on this line here. And we see this variation, obviously, the closer that we get to the heart. So aorta is going to have kind of these large fluctuations in pressure, which is okay because it's elastic, right? It's an elastic type of artery. And so it's able to expand and recoil very nicely. And that's exactly what it's designed to do. So just some trends to see. We've seen this pressure curve a lot, realizing that pressure is highest in the aorta, and then it's going to fall as we travel through the circulatory system all the way down to zero. So when we get to the right atrium, that pressure is zero, and what that does is it creates that nice, pressure gradient where we're traveling from a very high pressure to a very low pressure, and that's what ensures blood flow throughout our circulatory pathway. Okay, we talked about this before break two, and this is the relationship that we see between blood flow and change in pressure over resistance. Okay, so blood flow is directly proportional to change in pressure. So meaning that if we have change in pressure increasing, what's going to happen to blood flow? It's going to increase as well. Okay, so they're going to do the same thing. So think change in pressure as steepness of the curve. So if we look at the steepness of the curve through the arterial side of things, it can be very steep. So we have an increased pressure gradient. Whereas during the venous side of things, it's much less steep. In fact, it even kind of goes out to a flat line here towards the end. So that's what we see. That's what we see there. On the flip side of it, the relationship we have with resistance and flow is an inverse relationship. And so what happens there is as resistance increases, and we can think about resistance as being caused by several different factors like blood viscosity, blood vessel length, blood vessel diameter, which is probably the most changeable aspect of resistance. When resistance goes up, flow is going to decrease. And that makes sense. And we use the example of the straws, right? So you have the little coffee straw that you're trying to suck your coffee out of versus the big, like a bubble tea straw. So when resistance increases, flow is going to decrease. So an inverse relationship there. This is reminding you that arterial blood pressure is going to depend on some different factors. And so number one, we've got compliance of elastic arteries. And so that just means the ability of those elastic arteries with increased elastin to expand and then recoil. Okay. And then also think about the volume of blood that's pumped into those big elastic arteries closest to the heart. It's the most blood of the whole pathway, right? So the heart's going to pump and send out that wave of blood with each heartbeat. Closer to the heart, blood pressure is pulsatile. And so what we mean by that is basically these little pulses that you see. And we've talked about that before, but we're going to see those pulses. And then the further that we move away from the heart, we see less and less of that. So not really any pulses as we head into the smaller and smaller vessels. Certainly none in the capillaries. It's just kind of like a sludgy flow through capillaries. So we don't see those pulses or those variations in pressure there. Okay. Just another reminder, here's same information, just in a little different format. But here's systolic pressure at the top, here's diastolic pressure at the bottom. So here and here, and then this brings into brings us to our next concept, which is pulse pressure. And so basically what we see here is we can calculate the difference between the two. So we can say, well, we have a pulse pressure, and this is what we feel. So when you palpate, carotid artery, common carotid artery, or radial artery, you feel those fluctuations in pressure, and that's what you pick up as your pulse. And we can actually calculate a number for that. So we can take our systolic blood pressure and subtract our diastolic blood pressure from it. Okay, and that's going to equal our pulse pressure. So, for example, if we had just a typical systolic blood pressure of 120, and we subtract our typical diastolic pressure of 80 from that, we would end up with a pulse pressure of 40 millimeters of mercury. Okay, and that's simple, and that's an easy thing to calculate. So this is actually what you're feeling as your pulse, and I've included some very common pulse points where you can palpate your pulse. So common carotid obviously is a highlight there. Radial artery, when you palpate pulse at your wrist, is a nice one. Femoral artery is usually a pretty strong one as well. Posterior tib, down medial malleolus is a big one as well. Dorsalis pedis on the top of the foot. So those are all places where you can palpate that pulse pressure, and you're actually feeling the difference between systolic and diastolic. Okay, there's another calculation that we can do in regards to blood pressure, and this is what's called mean arterial pressure. So mean means average, right? So this is kind of our average arterial pressure that we see in one cardiac cycle. Okay, and so what do we mean by that? What's one cardiac cycle? If you think back, that's one heartbeat, right? So every time the heart beats, we can calculate a high and a low, our systolic and our diastolic, and then we can calculate an average. Okay, and so we do that. Here's our equation here. So mean arterial pressure is going to equal your diastolic blood pressure plus your pulse pressure divided by 3. Okay, so you're going to calculate your pulse pressure, which we just did a couple slides back here. Okay, so like on this one, we got a number of 40. So we're going to say, okay, we can take that 40 divided by 3, which is going to be a little more than 10, and then add our diastolic blood pressure back to it. And that's going to give us our mean arterial pressure. So it is important to note that our mean arterial pressure, it is not a halfway point. So if we look at, actually I'm going to back up, and it's nice on this slide. If we look here we already identified our systolic, we identified our diastolic. If we look at our mean arterial pressure, hang on. Our mean arterial pressure here, this is what we see here. Look, it's not halfway in between the two. Okay? It's not the halfway point. So that's because our heart actually spends more time in diastole. So it spends more time in rest than it does contracting. And so our mean arterial pressure is going to be biased a little bit towards the diastolic pressure of things, which is going to bring it down. So it's not halfway in between the two because our heart spends more time in diastole. And that's why we see a difference there. Okay. As we follow our path of blood pressure throughout the circulatory pathway and we get all the way down to capillaries, we are now kind of in this region, of this graph. And what do we see? Pressure continues to fall. It's decreased all the way down to like 35 millimeters of mercury and is even lower when it leaves the other end of the capillary bed. So we're talking low pressure. And I asked the question here, why would high pressure in the capillary beds be detrimental? So what's the problem with that? And we've talked about this before, and it's basically because those capillaries are one cell layer thick, and high pressure would damage them. So we need the pressure to be low so that we're not damaging the tunica intima of our capillaries. Okay. And if we continue through the rest of the circulatory pathway, we're now on the venous side of things. So we're now, venules coming out of capillary beds, combining to form veins, and then ultimately superior and inferior vena cava. So if we pick up our graph kind of in this area, what are we seeing here? Our pressure gradient is much less. So our change in pressure from one point to the next is going to be much less. So venous blood doesn't have the push of that large pressure gradient. So it needs some help. Veins hold a lot of blood in our pathway. So they hold like 65% of our total blood volume at any point in time. And they need some help dealing with all of that blood. So they need help bringing the blood back up to the heart. So we have what we call some functional adaptations that are going to increase venous return back to the heart. Sorry. So some of the things that we see that help our venous return or help the veins bring the blood back to the heart are muscle pumps. And basically what that means is we've got veins that are like embedded within muscles. Okay, so as your muscles contract and squeeze, it squeezes the blood up those veins. Okay, this is why getting up and walking around or having patients do like calf pumps will help them after surgery to keep that blood flowing so it doesn't just pool in their feet. Okay. The next one here is going to be our respiratory pump. So what this means is that every time you breathe, your thoracic cavity creates a negative pressure. And negative pressure is always going to be a suctioning type of pressure. So we have that negative pressure within our thoracic cavity, and it's going to basically create suction to pull blood from the legs back up into the thoracic cavity where the heart is. Okay? So that's a respiratory pump. And then the third thing is we have sympathetic vasoconstriction. And so what happens here is that we know that the sympathetic nervous system innervates tunica media in our blood vessels on the arterial side of things. So we are able to vasoconstrict in certain areas of the body. And if we're limiting blood going to some areas, that means there's more blood to return to the heart. Okay, so if we had just pervasive vasodilation all over our body, there wouldn't be enough blood returning to our heart in order to keep adequate blood flow to all of our organs. So we need to have some areas have their blood flow limited, and it's not limited to the point where it causes problems, but it's limited so that we can have adequate venous return back to the heart. And so all of these together, if you look at what's happening here, all of these are going to increase venous return. They increase blood flow going back to the heart. If we have more blood flow going back to the heart, every time the heart beats, we're going to have an increased stroke volume. So like how much that heart pumps out every time it beats is going to be increased. And then if we have increased stroke volume, if you think back about our equation here, this cardiac output equals heart rate times stroke volume. Okay, so if we increase stroke volume and cardiac output are directly related. So cardiac output is going to increase as well. Okay, and that's the relationship there. So what controls blood pressure? What types of things are going to factor in? And so these are things that are factors that play a role in blood pressure in the body. And we can take our initial equation that we had a few slides ago. If you remember, we had said blood flow equals change in pressure over resistance, right? So that's the first equation that we had started with. So now we can actually rework that, and we can say, okay, I want to solve for pressure here, because I'm really interested in seeing how these things affect pressure. So if I want to isolate pressure, I'm going to multiply each side of my equation by resistance. So we'll put a resistance over here. And now what's going to happen is that these guys are going to cancel out, and we're left with change in pressure equals flow times resistance. Flow times resistance. Okay? And then we can actually even tease that out a little bit more and just say, well, okay, we're just interested in pressure, not maybe necessarily the change in pressure, although it does change. So we can say pressure equals, we know that flow is our cardiac output, right? That was a measure of flow of blood to our entire body. So cardiac output times resistance. Okay? And we know that cardiac output equals stroke volume times heart rate. So we can even make this a little bit more specific and say stroke volume times heart rate times resistance. Okay, so we've just replaced our cardiac output with the two factors that contribute to cardiac output. So this is what we see here. So basically, these all have direct relationships to pressure. Okay, so if any one of these is going to increase, our pressure is going to increase, right? So that's what we see here. This is out of your Merriam textbook. And here we have, here's our mean arterial pressure. In fact, if we write our equation out again, pressure equals stroke volume times heart rate, hang on, that looks like a minus, times resistance. Okay, just by way of reminder. So this is what we see. We have all these factors that can contribute here. So here's our cardiac output, right? So anything here that increases cardiac output, like increasing stroke volume or increasing heart rate, is then going to increase our mean arterial pressure, right? And then anything that increases our peripheral resistance. And this is what we talked about before. We've got three main factors that contribute to resistance. So one of them is going to be blood vessel diameter, one of them is going to be the blood viscosity, and the other one is going to be blood vessel length. So if any of those create an increase in peripheral resistance, it is then going to increase our mean arterial pressure. So certainly knowing the relationships between all of those factors and how it affects mean arterial pressure is very important. Okay, I'm going to pause there and do a second PowerPoint. Okay, so I'm picking back up with part 2 of this blood pressure PowerPoint. And we had left off here where we were talking about contributions to mean arterial pressure and how cardiac output and peripheral resistance are our main factors that lead into that. So now we can talk about, well, how do we adjust blood pressure? So how does our body control it and regulate it? And so what we see are basically two different mechanisms for this. We've got short-term regulation, and so these are changes that can happen really, really quickly. And so as a result, quick changes are going to adjust mainly peripheral resistance, because how does that change? Resistance changes really quickly through diameter, right? So that's basically how this is going to work. And then also cardiac output. Okay, so either through heart rate or adjusting venous return, that's going to impact stroke volume. So that's what we see in the short term. And these are basically, we could write that these are kind of quick changes here. Okay, because we also know too that anything neural is going to be quick, right? They're fast changes. Hormones tend to take a little longer than our nervous system to exert changes, but they're still going to have an impact on resistance and cardiac output. Okay, and then our long-term regulation is going to be more through kidneys. Okay, and so basically what's happening with that is that kidneys are there to adjust blood volume. So that's going to be their primary goal. And so what do we know? How much blood do we have? We know we've got about 5 liters, give or take a little bit. And so our body wants to maintain that 5 liters. And our kidneys take care of that for us. So we'll talk about that in a second. So we're just going to run through these. For neural control, we already know that the medulla houses the cardiac center, right? We talked about this with the heart. So remind yourself of this. We have the cardioacceleratory center, which is going to increase heart rate. We have the cardioinhibitory center, which is going to decrease heart rate. So along with the cardiac center in the medulla, we also have what's called the vasomotor center. And so what we have here is a way for the brain to control the diameter of blood vessels. Okay? And so vasomotor, that should, prompt you to think like, okay, I've got contraction of smooth muscle. And so we know that that's how blood vessels are going to vasoconstrict. So medulla plays a role here. How do we do this? Well, we know that blood vessels are innervated by the sympathetic nervous system. And when that's activated, it's going to cause vasoconstriction, which we know is going to decrease the diameter of the blood vessels. And what happens to resistance at that point? Resistance is going to increase. And if resistance increases, what happens to our blood pressure? Our blood pressure is going to increase too. Okay. So that's the relationship there. On the flip side of it, if we have decreased sympathetic input, okay, so now we have more of a parasympathetic going on, but parasympathetic doesn't innervate blood vessels, so it's all sympathetic. It's either more when we have sympathetic reaction or it's less sympathetic. Okay, so decreased sympathetic input is going to have the opposite effect in causing vasodilation, which is going to decrease resistance because our blood vessel diameter just got bigger, and decreasing resistance is going to cause a decrease in pressure because of that relationship there. Okay, so that's what we see there. So what's telling the brain, what to do? What's giving information to the medulla so that it can make adjustments as needed? Well, we've got different types of receptors that play into this. We've got baroreceptors, we've got chemoreceptors, which we know respond to chemicals, and then we also have higher brain centers, and we'll talk about what type of information they give. So baroreceptors to start. Baroreceptors are special receptors that respond to the mechanical stimulation of stretch and pressure. Okay, so these are mechanoreceptors. They are located primarily in the large arteries of the neck. So internal carotid artery, aortic arch, and some of the other larger arteries that branch off of the heart. And so what you have are these receptors that are embedded in the walls of those vessels. And when we have increased pressure and stretch of those arteries, they are going to respond. Okay, so where we see this normally is when you are lying down and you go to sit up and all that blood rushes from your head and your upper body down to your feet, your arteries just decreased in size, basically, like they've got less blood going through them. So those baroreceptors will not be on stretch at that point. But it's going to cause a different type of reaction to help increase the blood pressure in that area so that you get enough blood going up to your brain. And some people will say that they feel kind of lightheaded when they change positions like that, and this helps combat that. But as you'll see, as we get older, we have a little less ability to do that, which is why some of your older patients might say that they feel lightheaded or dizzy when they change positions. And so we just need to let them sit for a minute, and the blood will come back up, and they'll be good. But what happens with these, with baroreceptors, when they're stretched, so when we have increased pressure, and it's putting those arteries on stretch, they are going to stimulate the cardioinhibitory center. Because what we don't want to have happen is we don't want them to be overstretched. We don't want too much pressure. Okay, so our body likes to keep our pressure within a certain range. So what's going to happen here is the cardioinhibitory center is going to cause pervasive vasodilation throughout the body, which we know is going to, that vasodilation is going to decrease resistance, which we know is going to now decrease our pressure, right? It's also going to slow down our heart rate because that plays a role as well in terms of cardiac output. And it's going to stimulate the parasympathetic nervous system to kind of calm things down a little bit. Okay, so that's the reaction that we have. That's what happens with baroreceptors when they're stretched. On the flip side of things, if we have a decrease in pressure, so let's say that you go from lying down to sitting up and blood flows from your head down, we just experienced a decrease in pressure in these arteries here. Those baroreceptors are inhibited because, again, they're stimulated with stretch, okay? So if they're not being stretched, they're being inhibited. That's going to result in pervasive vasoconstriction, which is going to increase resistance and cause an increase in pressure, right? That vasoconstriction is going to increase cardiac output and then further increase our blood pressure so that we can get blood back up to our brain. We don't feel lightheaded when we change positions. Okay, so our body likes to keep our pressures within that very narrow range. This is just basically, this is a summary of what we just talked about. This is baroreceptors. This is aortic arch here, and showing communication traveling up to the medulla in the brainstem and conveying that information. This is also a nice summary of what we just talked about. This is in your Marieb textbook. And so this is what happens. Here's our stimulus here of increasing blood pressure, which is going to cause those baroreceptors to be stimulated because, again, they respond to stretch, and we don't want too much pressure. So our body's reaction to that is to decrease pressure again. And we do that through, vasodilation, decreasing cardiac output, decreasing resistance to bring our blood pressure back down. And then on the flip side of things, here we have our stimulus of decreasing blood pressure, which our body wants to bring it back up again, okay, to keep it within that narrow range. So how do we keep it back up? We're going to inhibit those baroreceptors, which is going to cause vasoconstriction, increasing resistance, increased heart rate, increased cardiac output, all of which is going to lead to an increase in pressure to bring us back to that homeostatic range of blood pressure. Okay. The second way that the medulla gets information about blood pressure is through chemoreceptors. And so chemoreceptors, chemo means chemical, right? So these are going to be receptors that we find in the aortic arch and some of the other large arteries as well, same as the baroreceptors. It's just that this time they're going to respond to something a little bit different. They're going to respond to carbon dioxide, pH, and oxygen levels in our bloodstream. And so they're there. They're going to adjust blood flow based on presence of those chemical factors. And then also too, these chemoreceptors also play a significant role in controlling your respiratory rate and depth of respiration. And we'll talk about that when we do the respiratory system in a couple weeks. Okay, and then our third factor of controlling blood pressure is going to be the higher brain centers, and so they're going to play a role in conveying information from the medulla and heading to hypothalamus. So that's basically where we see most of this control coming from. So hypothalamus plays a role in our sympathetic fight or flight response, and then hypothalamus is also controlling part of the control system for sending blood to different areas of the body, right? And I kind of reminded you here, remember we've got exercise versus buffet, right? So where do we want our blood to flow? Do we want our blood to go to our gut? Do we want our blood to go to our legs? It all depends on what you're doing. So hypothalamus is going to play a role in that. We also mentioned that in addition to neural controls of blood pressure, we have hormonal controls. And so here's a few examples of hormones that help control blood pressure. So epinephrine and norepinephrine are our first two. These hormones are released when our sympathetic nervous system is activated. Okay, and they are going to increase vasoconstriction and increase cardiac output. And as a result, what's going to happen to pressure? So increasing vasoconstriction means increased resistance, increased cardiac output, right? What's the relationship here? What's going to happen to blood pressure, right? So we know it's going to increase, right? Direct relationship with all those. So epinephrine and norepinephrine result in increasing blood pressure. What's our next one here? Angiotensin. Okay. Angiotensin 2 is going to stimulate vasoconstriction throughout the body, and it also stimulates the release of aldosterone and antidiuretic hormone. Okay. So both of those are responsible for increasing blood volume. And we haven't done hormones yet, but when we get there, it's all gonna kind of come together. So aldosterone and ADH both prompt our body to increase blood volume. So instead of maybe 5 liters of blood, we've got a little bit more than that. So if we look at these factors, what just happened, if we have vasoconstriction, we know that we have increased resistance, right? If we have increased blood volume, what just happened to our stroke volume, right? It went up as well, because if there's more blood to be pumped, every time the heart beats, it's going to pump more blood with each heartbeat. So stroke volume just went up, which means that cardiac output went up as well, right? All of these things are going up. What's going to happen to our blood pressure? It's going to go up as well. Okay, so release of angiotensin 2 results in increasing blood pressure. Okay, that's those two. We've got a couple other ones, and actually I'm going to do ADH first, and that's this one right here, antidiuretic hormone. So what happens with antidiuretic hormone is that it stimulates your kidneys to increase water reabsorption. So instead of excreting that water through your urine, it's going to hold onto it. And as a result, it's going to increase blood volume. So basically, this does the same thing. It's the same thing as this, okay? So if we increase blood volume, we know that we're going to increase our stroke volume, which increases our cardiac output, which is going to increase pressure. So the net effect of releasing ADH or antidiuretic hormone is to increase blood pressure. So that's what we have there. Now, if you'll notice, all three of these, epinephrine, norepinephrine, angiotensin 2, and ADH, or antidiuretic hormone, have all had the effect of increasing blood pressure. We have one hormone that is like the odd man out, and it does something completely different. So, well, it's just the opposite. It actually is going to decrease blood pressure. So this one is called atrial, natriuretic peptide, or ANP. And this is actually a hormone that is released by the heart itself, which is kind of interesting. So the heart releases a hormone, and what this hormone does is it actually decreases blood volume, which if we have a decrease in volume, we're going to have a decrease in stroke volume, which is going to in turn decrease our cardiac output. And if we have decreased cardiac output, we're going to have decreased blood pressure, right? So you can kind of think of this one as kind of the odd man out, because everything else increases blood pressure, but this one decreases blood pressure. So it is a little different. And so I always tell students to kind of think about this as like the heart wants to protect itself. And so if the pressure gets too high, it's going to want to bring it back down. And so it's going to release, if the pressure increases too much for too long a period of time, it's going to release atrial natriuretic peptide to decrease blood volume and bring our pressure back down. Okay, so, all right. And then in terms of like long-term regulation, we've got our kidneys. And kidneys are responsible for adjusting blood volume, and they like to keep it, as close to 5 liters as they can. And we like to keep it within those narrow ranges. So when you eat a lot of chips, let's say, and your body retains a lot of water, it's going to help adjust. It might take it a day or two, but it's going to help adjust the blood volume there. Or on the flip side of things, if you are exercising and become dehydrated, we have the flip side. Maybe your blood volume decreases, where your kidneys are going to help conserve fluid to bring your blood volume back up again. Okay? And we do have this relationship here where increased blood volume results in increased blood pressure. And we know that's true because of that hydrostatic pressure pushing out, against the walls of the blood vessel on the inside. So the more fluid you have, the more hydrostatic pressure you have pushing out against the walls. Okay. So we're going to talk a little bit about hypertension. Actually, this is going to bleed through into our next PowerPoint. So we're almost at the end. So just briefly, because I'm going to pick this up on the next one, hypertension is diagnosed as a blood pressure higher than 140/90. Okay, oh, sorry. So some risk factors for hypertension would be hereditary. Maybe it's a genetic thing. Obviously, your diet, your age, the presence of diabetes is correlated to increased incidence of hypertension. If you're under a lot of stress, and smoking. So all of those are going to contribute. And then, like I said, I'm going to pick this up with our next PowerPoint, talking about changes to blood flow throughout the body with different activity levels. So we'll get that on the next one. Okay. All right.